Hello, I'm Dr. Jason Halperin. I'm the Director of Specialty Services at DAP Health, and I'm so honored to be here today to go over these questions. So let's jump right in. How can clinics increase patient access to providers? So when you're thinking about rapid antiretroviral therapy, probably the highest barrier is ensuring that your providers can see patients. And we've seen this from some of the data. The CDC just published a nice report of 455 HIV care facilities and found that only 20% offered same-day rapid ART appointments, though Ryan White-funded clinics were much more likely to offer same-day appointments. I think this is really integral. We need to develop workflows within our clinic setting where we're prioritizing seeing someone newly diagnosed. And how I've done this is I've ensured that we have a short appointment that is a dedicated appointment slot for someone newly diagnosed. So I can introduce myself, go over the benefits of rapid ART, and then initiate medication, and say at your next appointment, which will be 3 weeks later, we'll have more time to go over. Not having access to HIV tests was a major barrier also in terms of access to providers. And this could really be remedied by using rapid testing in clinic. I'm a big fan of using the 4th generation antigen antibody test as a finger stick. And if it's reactive, confirming that either with a finger stick Insti test or with an OraQuick test. If that's negative, you then have the discordance and you need to check HIV viral load. But if you use both of them in your clinic setting, well, then you could start seeing someone with a confirmed HIV diagnosis as per the CDC guidelines. Another big obstacle is transportation. So we've partnered with a rideshare service to ensure that we can overcome that transportation assistance. We use Ryan White money for that. You also have to think about not having penalties for being late, or really helping if someone no-shows to be able to come back quickly and soon. This is hard. I know it is. I know when someone comes late, that's really difficult for a provider. It's difficult for me. But saying to yourself, okay, how could I interweave them into my clinic workflow so that I don't lose that ability of seeing a patient? And then we should really reduce the requirements for documentation. If possible, self-attestation for how much you might make for Ryan White services is really, really important. And also ensuring access to medications, often with a starter pack, can be really, really helpful. So what is the best way to streamline patient intake to consolidate those visits? DHHS and IAS recommend rapid ART, so seeing patients as soon as possible after diagnosis. So we want to have that first appointment be about meeting a provider, developing that relationship, starting ART, and getting those labs drawn. And then maybe having a little more time to get the appropriate documentation to ensure insurance and Ryan White support services. So one of the ways to really overcome this barrier is having access to starter packs. So I use this in my clinic. If I use one of the recommended regimens, BIC, FTC, TAF, then it comes in a 7-day starter pack. I usually give 2 of those. So for 2 weeks, usually I'm able to get someone on insurance by then or a funding source. But if not, I'll give them another 2 weeks until we do it. That's really, really important. You should also be aware in your own locality, what are the ways to get people on Ryan White to cover for labs, or if you're in a Medicaid expansion state, how to get someone on Medicaid. And there's nothing that we could do more as HIV providers than advocate that every state in the United States becomes a Medicaid expansion state. It is essential for the care and services of people living with HIV. How should workflow and staffing be optimized to increase efficiency? Well, at my clinic, we had an incredible patient navigator, and I can't say enough about her. She would meet us someone, so let's say we had a new diagnosis, we got a call, maybe they were diagnosed at a sexual wellness clinic or an urgent care, or even they did a home test. They would call the clinic and it would be immediately, she had a cell phone, it would go right to her cell phone. She would meet them at the door. She would bring them into her own office so that she could fill out a few of the paperwork. We had it streamlined, and then she walked them right over to see one of the HIV treating providers. It was really important for everyone within the clinic setting to understand what a rapid start visit was. So maybe even the phlebotomist might say something about, welcome. We're excited you're here, and we're going to get your labs. We're going to go over it. You're going to go over with the provider in a few weeks. But having really that buy-in from the front desk to your nursing staff, phlebotomy, that's really essential. And then having dedicated staff that understand the paperwork and insurance verification and enrollment needed in each site. What I did, which was important, is for onboarding, I had a rapid start component to my onboarding. So I talked about the benefits of immediate ART, and I talked about U equals U. I mean, clearly we now have multiple studies that show no sexually transmitted infections, linked sexually transmitted infections when one of our patients is virally suppressed. So CDC, the Department of Health and Human Services, strongly endorse U equals U. We know that this decreases stigma and decreases external and internal stigma, and making sure our staff are aware of that. And as I said, making sure you have dedicated staff that understand the wraparound services that your patients might need. Let that be mental health services or dental services or housing or support for substance use. I still really believe in the directly observed therapy model. I find it so powerful in that first visit. If you can, I have an embedded pharmacy, so I understand the privilege of having that embedded pharmacy. But if you could have that medication that you hand to the patient, they open the medication, they start taking that medication right in front of you, there is nothing that builds that relationship stronger than that moment. As I always say, you're on your way now. This is that step to health, that step to U equals U, and I'm here for you. I'm committed. We are a partnership. Which patients are not eligible for rapid ART? Almost everyone. It's incredibly rare that I have a patient that is not eligible for rapid ART. The two populations are for specific opportunistic infections, TB meningitis and cryptococcal meningitis. I still believe strongly in a physical exam. I will make sure there's no thrush. I will ask questions about hemoptysis or weight loss. And of course, you're looking for any nuchal rigidity. I always stress a headache, especially someone newly diagnosed. That is not high on my concern list, but we have the ability with a good physical exam to see if there's any meningeal signs. And what would we do if we had a patient that we were concerned for cryptococcal meningitis or TB meningitis? I think this is really important to have that relationship with a hospital-based setting, because we should be having that person evaluated in the hospital. Once they're in the hospital and stabilized and started on therapy, then they'll be discharged, hopefully, back into your care quite quickly, because we do want to start ART soon, just not same day in those settings. And of course, you have to be aware of the drug interactions. So for tuberculous meningitis, if someone is on a rifampin-based regimen, I personally use Descovy or Truvada with dolutegravir Tivicay twice a day. And that's a really nice regimen to use. ART needs to be started and continued in that setting of OIs, because as we know from our literature, a secondary or even a tertiary OI is not uncommon. So you want to reconstitute that immune system as soon as possible. You'll have to be on the lookout of immune reconstitution inflammatory syndrome. So how about with patients with challenges, such social determinants of health, housing instability, substance use? Well, we have great data. Ward 86 was the first to publish this from University of California, San Francisco. I have published similar data in New Orleans that I don't see any difference in terms of medication adherence. If someone is interested and willing to start rapid ART, if they're struggling with substance use, mental health challenges, or housing instability. What I will say is it's essential to have those support services and link patients into mental health counseling or how best to access safe and stable housing, which can be very difficult, and I recognize that. But holding ART makes no sense in that population. This is still a life-saving medication. The other is pregnancy. We should be checking for pregnancy for anyone that can be pregnant, and even more so, we should be starting that rapid ART, or equally, we should be starting that rapid ART. We might be using specific medications for that population. We have great data for a dolutegravir-based regimen. There's some newer data with bictegravir, TAF-FTC, and I believe the guidelines will be changing soon. So please make sure that you're aware of what the DHHS guidelines are recommending for pregnancy. How should rapid reentry be handled? So I actually see this now more than rapid start. I see patients, I really believe in ensuring equal, equitable access for patients that have been out of care living with HIV. Well, we should make that as easy as possible. There should be a red carpet for returning to care. But these patients are a little more complicated. I don't have those quick visits for these patients. I've built in for a little longer visit because for me, it's really important that you ask these patients what medications they've been on and take a few moments, if you can, in your medical record to look for any previous genotypes. And selecting a regimen, it must be individualized based on the antiretroviral therapy history and then any known or suspected resistance. That said, our two recommended IAS regimens of co-formulated BIC-TAF-FTC or dolutegravir with either TAF-FTC or TDF-FTC are really, really powerful with a great backbone. I often start one of those regimens and then check a genotype. And then if I need to, I'll transition to something else. Also recognize that those medications cover hepatitis B. And if someone hadn't been immune to hepatitis B and they've been out of care, they could have contracted hepatitis B. So make sure you're testing for that. And then of course, if there was any concern for integrase resistance, for me, that's if they've been on elvitegravir or raltegravir and failed that regimen, then I'll more likely use a protease inhibitor-based regimen. And I typically use darunavir boosted with cobicistat TAF-FTC co-formulated. If a patient struggled to adhere to oral ART, we should really be considering long-acting. Many of you probably saw the incredible data from the Latitude study where the Data and Safety Monitoring Board stopped the study early because they saw that people who struggled with previous adherence did much better when transitioned to long-acting cabrylpivirine. So for me, I'm implementing that if I see a patient and they've struggled in the past, I'll start them on oral therapy. I'll usually start them on oral therapy because I have to do a PA for cabrylpivirine, and I'll say, let's start this oral therapy, and within 4 weeks, I'm going to see you and transition you quickly to long-acting cabrylpivirine. So it was great going over these questions together. I feel strongly about the importance of rapid ART and also rapid re-entry into care.